Marnie Nabudni, and welcome everyone to Grand Round for this week. I'd like to acknowledge that we meet today on the lands of the Kaurna people. I pay my respects to their elders, past, present and emerging. My sincere apologies, the sandwiches are a bit late, but we now have our presenters and we're ready to start, so I'm sure they'll arrive in due course. I'm very pleased to welcome today Dr. Alicia Callisto and Associate Professor Pravin Hissaria to talk about something we've heard a bit about this year, a new syndrome described in 2020, I think only, Vexas Syndrome, dawn of the new mutant. Promises to be an exciting presentation, so we can learn a little bit more about Vexas. Thanks, Alicia, take it away.
Hello, thank you very much for the opportunity for us to present to you today. I guess, like I said, my name is Alicia and we've got Professor Hissaria here as well. And we wanted to share, I guess, our experience from the Royal Adelaide Hospital in terms of Vexas. So we'll be going through a clinical case first, then what it is, and then some ongoing research for the future. So it all started last year where we're in immunology, we get a consult for another, what sounds like a drug rash to penicillin. We go see the patient on our usual Thursday grand rounds before we eventually have coffee. So managed to get the consultants to go see this patient. Sound like a pretty typical patient, 72-year-old man. He's got type 2 diabetes, gout, hyperlipidemia, hypothyroidism, right ear BCC and hemorrhoids. But on further history, I guess all was a bit more complicated than that. He'd been in hospital multiple times now with relapsing remitting febrile illness, and a clear diagnosis hadn't been established yet. He also had a below knee DVT, an embolic stroke, about 40 kilograms of weight loss. He'd had a PET scan for further workup of pyrexia of unknown cause. He just had some mediastinal lymphadenopathy and some mildly increased activity on his bone marrow. And of interest, he'd also had pancytopenia each time he'd had one of these flares. So he's had a bone marrow biopsy, but that didn't really establish anything too unique, just showed reactive marrow. And he also had macrocytic anemia with an IgA kappa paraprotein. Again, the significance of this was not very clear. Going back further, we were able to track his CRPs. And initially, they were all consistently between 200 to 300. There was no real clear reason why they were so high. They did go down for a period there, but then again, flared again when he came back to hospital. The orange dots there are the prednisolone dose. And so we weren't really sure what we were treating at that point, but he'd been started on high dose prednisolone, 100 milligrams, which you can see on the other axis. And almost instantly, the CRP dramatically fell. Very steroid responsive. And we can see that in March 2021, where the dose was reduced even by a few milligrams, he had a significant flare in his CRP. And that seemed to trend as the admissions continued. This wasn't a photo from our patient, but was a similar type of rash that was evident. And it seemed a bit atypical for a drug rash, more in keeping with neutrophilic dermatosis, and this is what was also found on the biopsy. And this seemed pretty similar to a clinical syndrome that was reported in a Journal Club article, which we had reviewed only a few weeks prior. And in this was the first case report of 25 men, all with this relapsing remitting fevers and neutrophilic dermatoses. It was published in NEJM. It was the only article published at that time in that year on this syndrome. And really, it's so rare that we wondered whether or not it could be this patient. In all 25 of these patients, they all had vacuoles present in their bone marrow. And so we wondered whether or not our patient would also have vacuoles present, and went to review his blood film. So this is just in the peripheral blood film, and you can see that there are vacuoles present. So it really almost suggests the diagnosis just from this, and the vacuoles being in the center of the white circles within that neutrophil there, in the vacuoles. So to confirm the diagnosis, we really needed this gene mutation to be confirmed. And at that point, we didn't really have a way of doing it within assay pathology apart from whole genome sequencing. And so that's what was completed for this patient. And it confirmed the UBA1 mutation. His specifically was in the valine amino acid within this codon, which is found on the X chromosome. And even though we were very excited at this point, we've found the diagnosis, we've nailed the diagnosis, but really the fight had just begun. So this was last year, but now the patient still continues to have ongoing flares despite treatment. Really, the only thing we have been successful with is high-dose steroids. Unfortunately, he's a bit of an unreliable patient. He's from the country. He's not always adherent to all of his medication. So he did come off for a period here, and then that's what led to this quite significant flare in August this year. He presented with severe abdominal pain, which initially was concerning for ischemic bowel, and so he underwent a laparotomy at that time. But within 3 days of 500 milligrams of IV methylprednisolone dramatically reduced his CRP and clinical symptoms along with that. He was maintained at 100 milligrams prednisolone initially, and then slowly reduced to 50 milligrams. Despite being on 50 milligrams at that time, he again had another flare. We also, at this time during that first admission, recommenced him on a JAK inhibitor called tofacitinib to try and keep his disease under control and add a steroid-sparing effect. But unfortunately, that was also not helpful, as he did actually have a flare on 50 milligrams of prednisolone. That second episode wasn't less severe than the initial one, but again, there was concern overnight for ischemic bowel, and hence he had another laparotomy. Currently, he remains on 50 milligrams of prednisolone. We're slowly reducing that down, but still remains, very refractory to other medications and disease-modifying agents. The only thing really now to consider going forward is a bone marrow transplant, but as you can imagine, this patient's elderly. He's been through a lot in terms of being in hospital multiple times, been on high-dose steroids now for a long time with the morbidity associated with that, but really we don't really have another option at this point. So we'll talk about the current trials with that later. We now have 4 patients in total with Vexas, just at the Royal Adelaide that we're treating, but after giving this presentation a week ago to the Rheumatology Society, there was a few people that came forward after that with a few other patients. So I think that, the more we understand it, the more we're testing for it, the more these patients are being found. But I just thought I'd focus on our patients for the time being. So they're all in their late 60s to 70s at the time of diagnosis, with a very sort of different clinical phenotype, but when you consider them together, it seems very obvious that they all fit that same sort of pattern. The patient 4, I'll just draw your attention to that, he has a different genetic mutation in the UBA1 gene, which has been shown, which we'll talk about as well, to have a more mild phenotype and an improved survival. So his sweet syndrome has been present for 12 years. And he really only manifested with more recurrent fevers and come to our attention more recently. They all had recurrent fevers, they all had neutrophilic dermatoses, one of them had chondritis, and most of them had had deep vein thrombosis or pulmonary involvement, and 2 of them had had orbital involvement. In terms of the hematology, all of them had had a bone marrow transplant by the time we saw them. And really all of the bone marrow biopsy reports were quite non-specific. It was only sort of reporting reactive changes, and it was only on subsequent bone marrow biopsy of the first patient that vacuoles were identified. The third patient was the only one to have myelodysplastic syndrome, and he is the most severely affected by the hematology side of things. And you can see they all have macrocytic anemia with very low hemoglobins and peak CRP, most notably for our first patient, but consistently elevated for most of them during the flares. In terms of treatment, they've all been very responsive to prednisolone, but as we've tried to reduce the dose, they've all fled. The lowest we've managed to get for most of them is 10 milligrams, and even dropping from that 12.5 to 10 milligrams makes a marked difference. And each time during the flare, they've responded well to either methylprednisolone or hydrocortisone. For the first 3 patients, we thought by targeting the downstream pathway of the autoinflammatory disease with JAK inhibitor would be the way to go. So that's why they were all on tofacitinib 5 milligrams BD. That's had a very clinical response. For the first patient, like we showed, he's had still ongoing flares despite that. Second patient was refractory to that and so was given tocilizumab, which is the IL-6 inhibitor. He got 2 infusions of that, but despite that, still continued to deteriorate and has unfortunately succumbed to his disease earlier this year. Patient 3 was known to the Rheumatology Immunology Clinic and had been on multiple DMARD therapies for the treatment of possible IgG4 disease, which is why he was on mycophenolate, methotrexate, and azathioprine, but that none of them were successful in reducing his flares. The 4th patient has been stable on 10 milligrams of prednisolone and has not been started on any disease-modifying therapy at this time, but he has ongoing morbidity from his previous thromboembolic disease and now is at very high perioperative risk going forward. So from that first publication in 2020, there's now been an explosion in the literature of case reports and further cohort studies to try and further understand this condition as well as predict its prognosis. And 2 of those are ours, completed here through the Royal Adelaide Hospital with the patients that we've discussed. So I just wanted to touch on, I guess, and explain what Vexas is. I think probably most of you might have realized now, but the name actually stands for the main features. So V is vacuoles, which you see in the blood film and the bone marrow. E is the E1 enzyme, which I'll talk about in a minute. And the gene of that is found on the X chromosome. The patients present with autoinflammatory syndrome and the genetic defect is somatic. And as you can see, so this is the initial publications description of the phenotype that they had at that time. And you can see that it's multi-system, multi-organ with chondritis, particularly of the nose and ears, the pulmonary involvement, myocardial involvement, also the bone marrow, which we've spoken about, hepatosplenomegaly, arthralgias, and the skin involvement with the neutrophilic dermatoses, as well as the deep vein thrombosis. So, ubiquitination is the post-translational modification of a protein. So the protein is already there in the cell. It just needs ubiquitin to be added to it to then carry out its function, which is most of the time to be degraded in the proteasome. The most important step is E1, and an E1 enzyme is UBA1, which is where that comes about. And if you lose the function of E1, you do not get the whole downstream pathway of ubiquitination. And so instead of the rest of the pathway occurring with the substrate being broken down by the proteasome, it accumulates, and that can then cause widespread inflammation and damage to the cell. It's restricted to just the myeloid lineage, which is why these patients sort of have quite a varied phenotype and also have pancytopenias during the disease flares, affecting the platelets, red blood cells, and the white blood cells. So it can correlate quite well with that as well. So this is the largest cohort. It's a French cohort of 116 patients. Interestingly, they weren't all male. So there have been case reports of a patient with Turner syndrome or a patient with X chromosome inactivation. A majority of them have skin lesions, majority being the neutrophilic dermatoses, recurrent fevers, weight loss, and sort of less likely to be involved are the myocardium and the renal tract. They were able to show a good correlation between the gene defect and survival, particularly the leucine variant being the more mild and best survival, and also having the least correlation with the MDS. So, when to suspect Vexas? If a patient's over 50, particularly if they're male, recurrent fevers, neutrophilic dermatoses, relapsing remitting inflammation, or unusual or recurrent clots. They can typically manifest as other clinical syndromes as well, and a lot of these patients who initially presented with these phenotypes were later found to have Vexas. And so it'd be important to consider Vexas in these patients as well, but not to exclude more common causes, as obviously Vexas is very rare. The main investigations include the CRP, noticing a macrocytic anemia, looking for lymphadenopathy on the PET scan, and inflammation on CT, and looking for reactive changes in the bone marrow. We now have a well-established diagnosis at SA Pathology, where we do Sanger sequencing for the UBA1 gene. So we're able to identify which mutation the patient has, and that's done locally. So the results are available within a week. So really a lot quicker than whole exome sequencing, cheaper as well, and gives you the diagnosis. So these are just the 4 patients that we have. They have a recognizable phenotype. We found a sort of thread that I guess links them all together, and we have a test which can show that. They are steroid responsive, and really it's also showing how clinicians can speak to each other in a way that we all understand between rheumatologists and hematologists, as opposed to, blaming one condition for the patient's symptoms on one thing or one on another thing. Can really work together to link those and treat them together. The patients have high morbidity and mortality, and we don't really have any good steroid-sparing agents at this time. They have a poor prognosis, especially with the late onset of disease, makes the ongoing treatment very difficult.
Thanks, Alicia, for giving that. So you can see how excited we were when we made the diagnosis, and literally that's how it happened. We saw the patient as a consult on a Thursday morning, went for coffee as we do, and then we actually went down, and the hematologist sit just next to my office, and we looked at the blood film and discovered that the granules which were being reported, toxic granules, were actually vacuoles. And since then, as you see, we've diagnosed 4, and we have at least 2 more in South Australia. But this particular syndrome has the potential to totally change the way we think at the adult onset diseases, particularly in terms of the contribution of the genetic element to the pathogenesis. So whenever we think about monogenetic diseases, we always think of young people who have strong family history, and that is because we are very used to thinking of germline mutations causing diseases. We don't think about the genetic contributions in adult diseases. And as you know, most of the focus on trying to have a genetic element in adult diseases, we are used to calling them polygenic, because the polymorphisms were all that we were detected. And that actually then comes down to this disease, and particularly to describe exactly how this was discovered, because it's a fascinating story, because this was a genotype first approach. So normally when you do genetics, you have this large worldwide cohorts whom you collect, who have some sort of standard clinical features, which combines them together, and then you do whole genome sequencing and try to see some commonalities. That's not how this paper was done. How they did this was that there is this young genetic consultant, Dr. Beck. What he did was he actually they've now differentiated the findings that they get on whole genome sequencing into pathway system. So what they did here was they were looking at the mutations that they would have found in the ubiquitin pathway, and to see if they could be clumped in to describe a particular clinical feature. So they went back and looked at about 2,500 whole genome sequencing results, and found this common mutation, which was present in about 3 subjects. What they then did was that they went and looked at the clinical features, and it was fitting in with sort of recurrent, systemic inflammation. And the reason why they chose this particular pathway was that this has now recently been described in lots of pediatric autoinflammatory disorders. And so this was just trying to be extrapolated to the adults to see if there is a different phenotype. And interestingly, most of these were in this specific codon, so in the exon 3 region of the UBA1 gene. and was causing substitution of the methionine and the amino acid at the 41 position. So it was very specific. So this couldn't have been an arbitrary thing. And all of these subjects were males, and hence it was thought that it was X chromosome, and that's where they found the mutation in. They then didn't stop at that, but then did the phenotypic analysis of these patients. And they found that all of these mutations, if they were inserted in animal models, were actually deleterious. So they had a functional phenotypic lab. And most importantly, when you go back and look at the public databases of these mutations, as you know, somatic mutations are present in all of us. They could not find this in the public databases. So that's how they zeroed in on the pathogenetic potential of this particular mutation. And then thereafter, this was all done in NIH, Cambridge. Thereafter, they went into the NIH databases for all other, undiagnosed diseases, whom genome sequencing was done, but no particular answer was found, and found that about 22 more subjects who had similar sort of clinical phenotype, all of them had these mutations. And most importantly, what they found was till this time point, so this is 2 years of work, they're still not zeroed in on the somatic mutation. So the reason why it is fascinating, the story is because this was a somatic mutation. Because when they separated the cells, they could not find it in the lymphocytes, but these mutations were restricted to the myeloid region only. Now, we all know that somatic mutations, as we normally think of, are only in cancers. But here you had a benign disease, and this is not the first. There have been somatic mutations describing like, PNH and LGL and so forth. But this was in an autoinflammatory condition where they found the somatic mutation, particularly in the X chromosome. And that begs to the questions as to what role do somatic mutations have in human disease, and particularly in adults. So we know that during the early part of the development in utero, there are somatic mutations that have been described and their associations with specific diseases, developmental abnormalities and so forth, as you can see there. But in the adulthood, there are only very few described somatic mutations. And that is because, as you can imagine, the somatic mutations are specific to that particular organ where it will manifest, where the disease is manifest. So the accessibility can become an issue. Germline mutations are easy to, I think I have a slide on that and I'll speak on that on my next slide. But this potentially has, as I said previously, strength to actually explain lots of those adult onset diseases where we've been thinking that they are usually polygenic, and we've been unable to find any specific environmental or epigenetic factors that could explain. And even more importantly, to explain the differences in the phenotype of one specific disease. So in autoimmune diseases, we are used to having, no one SLE patient behaves like another SLE patient, and similar things for vasculitis. And you would think that that possibly could be explained by the presence of somatic mutations in one of those rare, immune regulating cells, as well as those other conditions. And that's where this possibility, that's where this exciting discovery actually can lead to in the future. And you can see that we've already identified 6 patients only in South Australia. So you can imagine in 1 year to find 6 patients of what was called a very rare disease is very common, which means that, we need to start looking at things in such a manner. And that somatic mutations have been described in many organs. It is not specific to, initially we are used to thinking that they occur because only in organs which are rapidly proliferating, because each time a DNA undergoes cell division, it acquires certain certain defects which get repaired by mismatch repair enzymes or something. But sometimes they can just be leaky, and those somatic mutations can then persist. And we do know that they are not always deleterious. Some of them actually might be useful in terms of providing a survival advantage, as I will touch upon a bit later. And as you can see, there have been other diseases which are not quite malignant that have been described. The classical, I think one of the first ones was the PNH in the discovery of the PIGA gene in X-linked chromosome. And then we know that, the LGL leukemia, even cryoglobulinic vasculitis that occurs in Sjogren's syndrome, people have found that there are specific mutations in the B cells, which have also been described in certain non-Hodgkin's lymphomas as well. But these specific patients actually had that somatic mutation, which can predispose to cryoglobulinic vasculitis. And not just abnormal tissues, as I said, somatic mutations have been described to occur to the frequency of about 2 per 10 raised to minus 8 cells in normal organs as well. And we don't know exactly what that means. because they are not having any diseases. So this is just normal databases where people have sequenced these different tissues and have found, changes in the genetics which have not been found in other. And now, as you know, they have set up this whole somatic mutation database. And it's created a lot more interest after the publication of this particular syndrome in terms of people trying to go back and look into it to see if that can explain lots of these new diseases. So as I said, somatic mutation. Oh. Sorry, I think I forgot to put in the slide which talks about the differences between germline and somatic mutations. So I just thought I'll give you a brief primer about it as to what we mean by germline. So germline means something that you're born with. So that is present in the initial, zygotic phase when you get your genes from both mom and dad, and if there is genetics. And germline mutations is how we've normally been used to in terms of thinking the Mendelian patterns of inheritance and diseases. And because they are present in all the cells of the body, you can imagine, you can even do a buccal swab and you will find that mutation in the buccal swab. Whereas somatic mutations are specific to the cell type. So if you have to, and that's how they're common in cancers, because cancer is a specific cell type. You can take out the cancer, do the sequencing and find the mutation there. But if you were to find somatic mutation in a normal cell where it is not undergone clonal proliferation, you can imagine that it will be a lot more difficult, as we found in Vexas, that it was present in myeloid cell lineage. Now, the reason why they picked it up in the whole gene sequencing was that this particular mutation did not lead to depletion of all myeloid cells. And hence they could find it using normal sequencing mechanisms. Let's say a brain tumor. Now, you would actually need a brain tissue for it to be able to make a diagnosis. Now, you can do that for tumor, where you can go ahead and biopsy, but you can't do that for Parkinson's, let's say. You're not going to do brain biopsies to find out those mutations. But this particular discovery has opened up that possibility, and people have started talking about doing that kind of research studies. And the other thing is, it is very difficult to assess somatic mutations as to what they mean when you actually detect them. Mainly because the modern gene sequencing goes into very deep dive into your gene sequencing, and you will be able to detect any differences down to about 1 in a 1 million cell, right? But when you do the bioinformatic analysis on it to find significance, as you can imagine that if we were to, let's say, sequence all the people sitting in this room, you're going to find about 500 different types of genetic variations as compared to your normal database, so-called normal database, all right? So when you actually go around trying to assign significance to what you have discovered in the gene sequencing, you actually zero down on the prevalence of that particular mutation. So you can imagine that anything which is low in numbers will be discarded unless it is relevant to the pathway that you are interrogating. Yeah. So all of these somatic mutations are there. So these Vexas, they already had these mutations, which was already described. So and they went back to about 5 years. One of the patient in that 25 cohort had the gene sequencing done 5 years ago. So this was already known, but this was discarded as part of the bioinformatic analysis to find out what was more significant. So these are just hiding in the plain sight. But as I said, they might be important for lots of adult onset disorders. So for example, schizophrenia. They have found that they have certain increased presence of somatic mutations in the particular region of the cerebral cortex if you biopsy them, right? So which means that there's a specific biopsy which alters, I think it is the GABA transmission pathways. So this has that potential that, genetics possibly can explain the way different adults get diseases, rather than going back to the environmental or epigenetic factors as we've been used to. And lastly, the UBA1 gene that has been found to have a very tight genotype-phenotype correlation. So it's a very unique thing happening at that particular space. They have shown that it causes defects in your ubiquitination pathways, and the mutation, they've not done the functional analysis to say why, some are milder, but they have found that certain people having certain type of genotype have a milder disease. Some people have more MDAs, that clusters. So that clustering of the genotype-phenotype correlation is also being found in this disease, which is not common when you talk about adult onset multi-system diseases. Now, going back to the few clinical features, actually, which are very exciting about this, obviously vacuoles, which have never been reported before. I looked it up last night, actually, how specific were these. So they are quite specific because there is at least one study where they went back and looked at about 10,000 bone marrows and found that only about 23 of them actually had vacuoles in them. So they are quite specific. But the other diseases which can cause this is alcohol intoxication, copper deficiency, zinc toxicity, and lots of myeloid neoplasm, as we all know, can cause it. So if a myeloid neoplasm patient presents with more an inflammatory phenotype rather than pancytopenia and bone marrow failure phenotype, that's where you start looking for this particular syndrome. Whether bone marrow should be done in all Vexas patients? Possibly yes, because that is where the specificity of finding a vacuole, and also it increases the pickup of the UBA1 gene mutation. Peripheral blood usually picks it up, but if they are really severely pancytopenic, you might not find it to the frequency. So bone marrow should be done. And they have found that most of these patients have macrocytic anemia and lymphopenia. So you would not possibly get a diagnosis of Vexas from, they have these non-specific features. But if you did a bone marrow for a hematological indication, where it was only reactive with macrocytosis and severe lymphopenia with some vacuoles, that's where you start thinking about Vexas. As you would expect, in last 1 year, people have started looking at these different cohorts of diseases, which initially were labeled as something else. So the three main cohorts were the relapsing polychondritis, the myelodysplastic syndromes, and the neutrophilic dermatosis. And at least in relapsing polychondritis, NIH has gone back and looked at this big case series of about 98 subjects, where they found 13 of them actually had this mutation. And they've gone further to look into the clinical characteristics as to how they could now differentiate if there was going to be another patient who walks in with a cartilage inflammation. And they've come up with this simple algorithm of MCV and a platelet count, which would give almost, as you can see, 100% specificity, 100% sensitivity, and a very high specificity. So cartilage inflammation in an adult, actually, you should look for just simple hematological parameters, and that could possibly give you this diagnosis. However, as Alicia said, it's exciting to diagnose a disease, but even more depressing when you know the diagnosis and you can't manage it. So we still don't know the optimal steroid sparing therapy. As Alicia said, one of our patients is requiring 50 milligrams of prednisolone. He flares up every time we go below 50 milligrams. So that in itself is actually unnerving, and that's why we've been thinking about bone marrow transplant. There are few studies that are being done now, and we opted for JAK inhibitor last year because at that time this publication had not come in, the one that you can see displayed now. And we thought that if we go for something which is more downstream in terms of being able to alter multiple cytokine signalings, that might be a better way to go. And that's why we went for JAK inhibitor. Tofacitinib we could gain through the compassionate access program, and then we went for it, and 3 of our subjects are on that. But now we have this publication which says that ruxolitinib, which is another, as you know, there are about 8 JAK inhibitors now, at least 4 of them licensed. But it seems like ruxolitinib might have been a better way to go, because the difference being that it targets the JAK1 and JAK2 more than JAK1 and JAK3, which is what tofacitinib does. And we have other specific, just JAK1 alone inhibitors as well. So it will be interesting, and we still think the money is going to be in JAK inhibitors in terms of long-term medical therapy, at least, if they can't be worked up for the bone marrow transplant. People have talked about tocilizumab as well. We don't know how long it should be given. Definitely in acute episode, as you would expect, it will work, because as you saw the CRP levels, even in sepsis, you don't see them that high. So that can be another clinical pointer towards suspecting it when you get a patient with recurrent inflammation. There have been case reports, but not large trials, and we could not see anything on the clinical trials website as well in terms of anything that is ongoing. As you would expect with anything which is based in a hematopoietic stem cell, bone marrow transplant can be curative. There is this publication with 7 subjects, all of them very young, as you would expect, and at least 6 of them showed very good survival. They did need intensive conditioning and everything, so it would be an issue in terms of transplant-related mortality. Our subject that we are talking about with we are discussing with hematologists is 72-year-old, so we're not sure if we'll get across the line to convince them. But the patient he actually looks like Hager. That's why Alicia put up that photograph. So he is that big, and he's up for it. He's read everything about Vexas now. He's become a lot more compliant now. As you saw, initially he was not actually. He used to get angry each time he would see anyone. But I think he's coming across, and he's happy actually if he can find him a mad donor, that is, because he has only 2 siblings, and he doesn't think they will donate their bone marrow. In terms of prognosis, elderly onset disease, so 5-year survival rate of 63% is not that bad. So I think we should be working hard on this, on the diagnosis and treatment of these diseases. And the poor prognostic marker, these are all small cohort studies. So the most important, I think, one to look out for in terms of poor prognostic markers would be the genetics of it, rather than going for clinical features, because these are small cohort studies. So one patient here and one patient there can actually totally skew the statistics. But I think the genetics is standing out, which is very interesting. So it's exciting about this disease is that we finally found the link between clonal hematopoiesis and systemic inflammation. There has been one before, which, as you all know, stage 3 gain of function mutation with LGL leukemia and Vexas syndrome in rheumatoid arthritis that we knew of. Although that's quite rare and it's not a life-threatening disease, so it is less discussed. But here we have found something which is roaringly inflammatory and the pathway, and we've known a lot about it. The clinical spectrum is expanding each day as we speak. You know, it's truly a multi-system disorder, and that's one thing that will have to be worked out as to why it causes inflammation in this niche, you know, cartilage areas and not joints, as we are more used to with all these multiple autoimmune conditions. So that still needs to be worked out, but that clinical spectrum is expanding, but it should be suspected in any male patient, elderly with unexplained inflammatory syndrome. We don't know still what is the optimal management. And most importantly, the publication of this syndrome actually opens up, as I said, a whole new Pandora's box about the way we look at the pathogenesis of adult conditions. And I think the genetics is again going to come back big way. It has already actually, and I just granted about 40 million for looking back at somatic mutations in adult onset inflammatory diseases. So I think this will open up a whole new avenue in terms of bioinformatics. And also, by applying the strength of single cell sequencing, as we all know now, so it's very expensive currently, but we know that with these kind of newer technologies, they become cheap quite very quickly because all of that is automated. Hopefully, with single cell sequencing, then it should become very important in terms of the discovery of these pathways, because then you can do single cell sequencing on a white cell, on a dendritic cell, on a B cell, and that possibly is going to tell us the answers about the differences in the disease phenotypes that we see with lots of autoimmune conditions. And hopefully, lastly, it will lead to targeted therapies. The small molecular inhibitors are hitting, as you know, there's a SIB or a NIB being published in NEJM almost every second week. So it's the most exciting times in terms of new drug discoveries, especially in adult diseases. And most of these were being discovered for cancer and now are coming through to the inflammatory diseases and should open up a whole new avenue. So hopefully we will find a new UBA1 activating small molecule. As Alicia mentioned, actually we are now part of an international autoinflammatory disease registry where we are recruiting these patients. When Alicia gave this talk in the rheumatology last week, I think they've already said they have about 2 more already here. And there are about 6, I think, in Sydney. So we're trying to collect all of them to see if we can learn more about it and contribute to the world literature. Thank you.
Thanks for that exciting talk. It's really inspiring. I wanted to ask Alicia about the clots. Are they predominantly arterial or venous, or can you get both?
You can get both, and they're predominantly venous though. But I guess there's a combination of, you know, the other features, where like the patients are in hospital for a very long time, whether or not that contributes to it.
And they're elderly.
They've all had operations and so many other things. Then there's the argument that, you know, you're giving them a JAK inhibitor, is that going to cause more problems as well? Potentially. There's a really nice, I didn't include it, but there's a really nice flowchart in one of the journals that has about 20 arrows that sort of contribute to the whole pathogenesis of them.
The true multifactorial pathogenesis, yeah. All right, yeah, now.
A couple of questions. Firstly, what do you see on histology of lymph node, let's say, an organ biopsy, maybe neutrophils? And the second, you know what the genotypic mutation, whether it can be manifested as silent node, like with mildly or no, you know, what you're seeing is a phenotype, and you don't know about how prevalent this genotypic mutation is.
Yep. So no, it was not found in the public database. That's how they zeroed in on this particular mutation during the initial discovery process of those first 3 subjects. So it was not described in the public database. So number 1. Number 2 is germline mutation of UBA1 is known. It causes spinal muscular atrophy. So there is germline mutation of this, which causes SMA. The somatic mutation is a different story because the phenotype is totally different, but the germline mutation causes that. And thirdly, yes, it would be functionally significant because they did the in silico analysis before they went on looking for it in the larger, cohorts. So they did the in silico analysis where they showed that these white blood cells or macrophages mainly of the myeloid cell lineage, they were highly excitable.
At what age do we think the mutation occurs? And presumably the patient or sufferer would go through a sort of transition hybrid phase. And so these cells must have some sort of survival advantage as compared to the unmutated cells. So what's that survival advantage? What age does this happen?
Survival advantage, I'm not sure if that's the case, because this pathway, by inhibiting it, I don't think it should give any survival advantage. But you're right about the duration that this mutation would be there before it fully manifests. And the only studies that have been done is with the SNVs, so single nucleotide variation fragments, in terms of trying to see the prevalence of this mutation in terms of percentage of cells that it affects, and see if that burden of abnormal cells manifests as disease or not. So initially there was a publication earlier this year which said that SNV cutoff of about, I think, 25%. More than that did actually associate with a more severe disease phenotype as compared to the lesser SNV. Subsequently, there are about 2 or 3 publications which are not quite agreeing with that particular finding. So I think the jury is still out on whether that is going to be the case, the burden of mutations in the myeloid cells that is important in terms of separating the disease severity. But the location of the mutation and the particular type of mutation definitely is being associated with disease phenotype. Now, whether that can be modeled onto an animal system to find out what specific does has not been done so.
If I can sort of follow that up. So if it's only a percentage of the myeloid cells that have this somatic mutation, when you're doing a bone marrow transplant, you basically get the patient's bone marrow and sort it. So you're getting rid of those cells and stick the same amount of bone marrow back.
I think it'll be difficult to say that because you'll have to destroy all the stem cells, because there will be 1 or 2 stem cells that will be having this. So I guess differentiating that and without blasting them heavy with all severe ablation, it will be difficult to do. And if you did that at that age, I don't think autologously they'll survive if you don't give them another healthy marrow.
But it's interesting because the myeloid lineage survives. So if you get this mutation in the lymphoid lineage, then the patient won't live. Which ends what they found in the animal model. So if you have the genetic defect from when you're born, like these that use zebrafish, then they all get ataxia. So it's really interesting at the different time points as to what disease phenotype they get.
You can't fix the mutation genetically.
No, so that's what I meant by. So that's what I meant by the small molecule, which can cause gain of function in some of these pathways, especially with enzymes. I think we're still 10 years away from that, but that is going to be one of the things where mRNA vaccines are going. They're going to be a lot. So let's say if they have this genetic mutation, you form an mRNA vaccine which delivers UBA1. Even if you have to give it every 6 months, because the protein won't last, mRNA doesn't last for more than 21 days. It will cause translation of that protein or expression for maybe 3 months. If you had to give that injection every 3 months or something, that will be worthwhile. And that's where all the mRNA field is going now. Obviously, it's gained its reputation with COVID and everything, but I think rather than infectious diseases, these diseases will be more exciting to see if that can be done.
Analogy with other sort of somatic mutation diseases, cancer. Was there any evidence of any common predisposing germline mutations in the patients?
germline mutations in these patients?
So within the, are there any predisposing mutations on the germline that predict or anticipate somatic mutation?
Or in general,
Yeah.
you mean? In general?
Well, within this disease, but
Oh, in this disease, no, I've not read anything. In general, you would think so. Definitely. One of the mismatch repair enzymes or one of those DNA regulating or the ligases or something, you would think that there would be the alteration in one of them, even if it is polymorphism or reduction in function, would lead to acquisition of more somatic mutations. But then, as I said, they are so common in healthy individuals. So
with one of the elderly patients that I've been involved in, I had hoped to spare him the second laparotomy.
yeah.
Because it was so similar to the first presentation.
Even
The
first
thing
time we
is-
said no.
Yeah. But
We
I had
clearly
no-
wrote
I had
it's not
no
required.
way of convincing the surgeons, but because I guess ischemic gut could have been a possibility, and so that was their last bastion. But I just feel like it's kind of like this very sophisticated understanding, and we still use blunt clinical tools like having to use high-dose prednisolone. I suspect we're going to find a lot more of these cases, don't you?
Definitely.
I
Most
keep
definitely.
thinking back to cases of chondritis
Most
that
definitely.
I couldn't puzzle out. Elderly men that we didn't have an answer for some of their
The-
fevers.
Yeah, the third one, the one which was followed up in the rheumatology immunology clinic, and I've been seeing him for 4 years. And we called it IgG4,
Yes.
as you need to have a diagnosis to give them steroids. So we come up with
That's
some
right.
when we can't find something. And that was very loosely based upon, I have always written query IgG4 because I was not convinced, but then, the pattern of inflammation and he had parotid enlargements as well. I was sort of talking myself into the diagnosis and we tried all of that. And then we had this patient and he came in with an ear pain and I said, oh no, male with ear pain.
Well, I think having a registry is a great way forward, isn't it?
That's right.
And it is a really exciting story. People online have said that they thoroughly enjoyed the presentation, but no one's had any questions for you. Anyone from the chat? Any further questions in the room? Well, I thought I was coming along to hear yet another Vexas presentation, but actually you've done a fantastic job. It's been a great case presentation, very worthy of Grand Mount, and a really good illustration of the breakthrough in this topic. Thanks so much.
Thanks.
Thank you.